Good afternoon, sir. Good afternoon, my mentors, my seniors, and my colleagues. Today I'm going to present on transforaminal endoscopic discectomy decompression in migrated disc prolapse. It is a study of 129 patients. So PTLD has many advantages, and it is mainly used in non-migrated and low-grade migrated disc herniations. But many earlier studies, as shown, some of them are shown down, have recorded a high failure rates in the high migrated disc herniation, and open surgery are generally suggested by them. This is mainly because of the hidden view of the disc in the endoscopic vision and the various anatomical difficulties like the facetal hypertrophy, then foraminal ligaments, sub-PLL disc, in-plate spurs, and the pedicle anatomic hindering the vision in the endoscopy, and also the various compounding access difficulty at the L5-S1 level. But now the era has been changed, and many spine surgeons have developed various new great techniques like the foraminoplasty, the transfacetal approaches, and the pedicle complex approaches. The aim of my study is to analyze the outcome of the transforaminal endoscopy discectomy decompression in the migrated disc prolapse in the 129 patients. It is a retrospective study carried out at Savya Spine Institute and BIMS. The total of 129 patients are enrolled from 2010 to 2021. All the informed consents were taken preoperatively. The inclusion were the intracanalicular extrusions and the sequestration from L1 to S1 level, and follow-up at least 12 months is there. In the exclusion criteria, the foraminal and the extraforaminal discs and the discs without any cranial and the caudal migrations are excluded. The MRI scans are done in all the patients to determine the level and the extent of the pathology. All cases were done under the local anesthesia. Then the intraoperative fluoroscopic examination was done to ensure the correct positioning of the endoscope. And after that, the discectomy procedure is done in the form of inside out, outside in, and the transpedicular techniques. Then the successful removal of the migrated disc was determined using the intraoperative findings such as the probing, visualized fluttering, dural pulsations, fallback of the dural roots, and loose neural elements, and of course the retrieved disc fragments. If any residual fragment non-symptomatic remained, then the patient is then observed. Generally, the patient is discharged on the first day itself, on the day of operation. These are the results showing the demographic data. The mean age in our study is 42.79 with a standard deviation of the 9.52. 87 males and 42 females are involved. The L4, L5 is the most commonly operated level, followed by the L5-S1. This is the least classification. The zone 1 and the zone 4 shows the high migrated disc prolapses. Zone 2 and zone 3 shows the low migrated, whereas when the disc prolapse, disc extrusion crosses the inferior pedicular margin above or below, then it is called as the high migrated disc. Total 61 low migrated disc prolapses are operated, and 68 high and very high migrated prolapses are operated at our institution. Then down migrated disc prolapses are operated most commonly. The in-out technique is used in 98 patients, and the foraminoplasties are done at L5-S1 level the most commonly. These are the various clinical criteria we have measured. The ODS and the VAS score is clinically significantly and statistically significantly reduced in our study. The time of the surgery is noted, which came out to be 76.49 minutes, and the fluoroscopic, around 19 fluoroscopic sleuths are being taken. Then the patient satisfaction index is 1.14, which is excellent. Then the return to work is within 3 weeks, and the MACNAB outcome is 127, which is excellent. These are the various complications which are noted in my study. The peroperative facet fractures intraoperatively is seen in one patient, but the patient is absolutely fine. The protraumal convulsion is seen in one patient. For that, we waited for 10 minutes and resumed the surgery. Then the residual minute fragments in the postoperative MRI are seen in 9 patients. The MRC power getting less than 3 was seen in 15 patients, but it was recurred in all the patients in 6 weeks. The recurrences are seen in 2 patients. The one recurrence is in one patient, the recurrence was there after 2 years, for which the patient again opted for PTLD and the patient is absolutely fine. And the another patient underwent the MLD and after that the TLIF in 1 month, in the period of 1 month. The post-op diaesthesias are seen most commonly in 7 patients. These are the various PubMed published studies showing almost the similar outcomes as our study. In all the studies, the ODIs and the VAS is significantly improved, and the Macro score is in all the studies more than 90, which is excellent. These are the various complications noted, the most common being the tingling and the numbness and the dysesthesia in the patients. These are the various studies showing that the minimal invasive endoscopy, that is transforaminal endoscopy, is safe, viable, and the effective procedure. These are the various cases operated at our institution. This is a L2, L3 down migrated disc, and it is operated with the in-out technique and giving the best decompression post-operatively. This is again a down migrated disc at L4, L5 with the in-out technique and again giving the best decompression. This is the up migrated disc, again with the in-out technique and showing the best results. This is again a down migrated disc at L4, L5 operated with outside in technique, and the good decompression is shown. So the conclusion of my study is the transforaminal endoscopy is a very safe and excellent technique, giving the very favorable outcome in the cases of the migrated disc prolapse, even in the high and very high migrated disc prolapses. The limitation of my study is, it is a retrospective study, it is non-randomized, non-continuous, with no comparative arms, and implicit bias cannot be excluded. Thank you.